Hello students, good morning everyone. I am Dr. Anagha and in today's session we are going to learn about antepartum hemorrhage. So let us begin with the session. So what do you mean by antepartum hemorrhage? It is defined as bleeding into the genital tract or from the genital tract after the period of viability. Now this period of viability varies from country to country, from institution to institution, because it depends on the number of facilities which are available in the NICU. So as per the recent edition of DC Datta, it is given to be 22 weeks of gestation. So we can define APH as bleeding after 22 weeks of gestation and before the birth of baby. That means stage 1 and 2 of labor are also included in the definition of APH, right? And if the bleeding occurs before 22 weeks of gestation, then we are going to call it as abortions. Alright? Now let us understand the causes of this antepartum hemorrhage. So mainly there are going to be three causes. First one is your placental cause, which contributes to 70%, and it occurs due to placenta previa and abruptio placenta. Another one is your extra placental causes, which contributes to 5%, and it includes all cervicovaginal causes like cervical polyps, cervical varicosities or cervical trauma and other cervicovaginal lesions. Also, carcinoma cervix can also lead to antepartum hemorrhage. Another one is your unexplained or indeterminate cause, which contributes to 20 to 25%, and it includes your vasa previa or succenturiate lobe. Alright, so these are your three causes of antepartum hemorrhage. Now, in today's session, we are going to learn about placental cause and mainly placenta previa. So, let us understand what is placenta previa. So, when the placenta gets implanted into the lower uterine segment and if it covers the cervix completely or partially, then we are going to call it as placenta previa. So, normally this placenta is going to get implanted into the upper part of the uterus, right, into the fundal region. As you can see in this image, this is your normally implanted placenta. But when this placenta gets implanted into the lower uterine segment, then we are going to call it as placenta previa. Now, another question, how does bleeding occurs due to placenta previa? How does it lead to antepartum hemorrhage? Now, what happens here is that around 20 weeks of gestation, this lower uterine segment is not developed until this weeks of gestation. This lower uterine segment is developed from isthmus, right? So isthmus is around 0.5 centimeter around 20 weeks. And after that, what happens until the pregnancy gets term pregnancy, it elongates almost 10 folds and becomes 5 centimeter at term and forms lower uterine segment. So during this elongation of the isthmus or during this formation of lower uterine segment, as the placenta is implanted into that area and due to a lot of activity happening there, and due to the disproportion which is causing between that inelastic placenta and between this uterine wall, there can occur a little bit of separation of the placenta from the uterine wall, and this little separation from the uterine wall of placenta can lead to vaginal bleeding. Okay, so this is the cause of bleeding in placenta previa. Alright. Now let us look at this ultrasound image to understand the placenta previa. These are your fetal parts. This is your placenta and this is your cervical canal. This is your internal os. So as you can see, this placenta is completely covering the internal os lying into the lower uterine segment. So this is your placenta previa. Alright. Now let us understand the risk factors. What is going to increase the incidence of APH or placenta previa specifically? So, first one is your multiparity. Another is your maternal age. If it is greater than 35 years, if there is an advanced maternal age, then the risk increases by 4 times. If there is a prior C-section, then the placenta might get implanted onto that previous scar of C-section. Prior curettage, prior placenta previa, if there is a history of placenta previa in previous pregnancies, then there is an increased risk of placenta previa in current pregnancy also. Multiple pregnancy. As we have seen in our last session, multiple pregnancy can lead to antepartum hemorrhage. So how does it lead to placenta previa? If there is a twin pregnancy, there might be 2 separate placentas or 1 single placenta, right? So if there are 2 different placentas, one placenta might encroach into the lower uterine segment. And also if there is a single placenta, it might be a bigger placenta, and that can also encroach into the lower uterine segment. So this is the reason for placenta previa in multiple pregnancy. Now smoking also increases the risk of placenta previa because smoking increases the placental hypertrophy, right? Then succenturiate lobe. If there is an adjacent lobe to the normally placed placenta, then that lobe can encroach into the lower uterine segment, right? So these are the risk factors for antepartum hemorrhage. Now let us understand the degree of placenta previa. So as you can see, this is known as Brownie's classification of placenta previa. There are 4 different types of placenta previa. So type 1 is known as low-lying. And what is low-lying placenta? When the placenta is lying within 2 centimeters from the internal cervical os. This is your internal cervical os and this is your placenta. So when it is lying within 2 centimeters, then it is known as low-lying placenta. Type 2 placenta previa is marginal, which again has 2 types, anterior and posterior. If the placenta is placed anteriorly, then it is anterior type 2 placenta previa. If it is placed posteriorly, then it is posterior placenta previa. As you can see here, the placenta is just touching the internal cervical os. That is why it is known as marginal placenta previa. Type 3 is your partial. When the placenta is partially covering the internal os, as you can see in the image, it is covering internal os partially, then that is your type 3 placenta previa. In type 4 placenta previa, placenta is going to completely cover the internal os. So these are your 4 types of placenta previa depending on the how much amount of placenta is covering the internal os. Okay. So Brownie's classification was an old classification. As per the revised classification, there are only 2 types, placenta previa and low-lying placenta. So placenta previa means when the placenta is implanted over the internal cervical os, it is called placenta previa. So it includes your type 3 and type 4, right? And when the placenta lies within 2 centimeters of the cervical os but does not cover it, it is called low-lying placenta. Okay, so this includes your type 1. Now, another important thing is dangerous placenta previa. This is the name given to posterior placenta previa. Now, what happens in posterior placenta previa? As you can see, actually these are the images of normally placed posterior and anterior placenta. Now to make it posterior placenta previa, we are going to place this placenta a bit into the lower uterine segment. So this is your posterior placenta previa and this is going to be your anterior placenta previa. Now what happens in posterior placenta previa is that major thickness of placenta previa is going to overlie the sacral promontory. Here is your sacral promontory, right? So due to this overlying of the placenta previa over this sacral promontory, it is going to diminish the antero-posterior diameter of the inlet. What do we call the antero-posterior diameter of the inlet? It is also known as true conjugate, right? And it extends from the upper border of the symphysis pubis to the tip of the sacral promontory. So this is your antero-posterior diameter of the inlet, and due to the diminution of this antero-posterior diameter, it prevents the engagement of the presenting part of the fetal head, right? Because how does the engagement occurs? The presenting part enters the pelvic inlet through the antero-posterior diameter, and it gets engaged, or it comes till the level of ischial spines, right? So that is what we call it as engagement. But due to this diminution of antero-posterior diameter, it prevents the engagement of the presenting part. And what does this lead to further? Due to this prevention of engagement, it hinders the effective compression of the separated placenta. Now normally what happens, as the fetal head get engaged, it will compress that separated placenta, and due to that compression of separated placenta, the bleeding will stop, right? But here, as there is prevention of engagement, there will be no compression of the separated placenta, and that is why the bleeding won't get stopped, and that will lead to heavy bleeding or profuse bleeding, and that is why posterior placenta previa is also known as dangerous placenta previa. Alright? Now, let us understand the clinical features of placenta previa. So, the main symptom or the only symptom of placenta previa is going to be vaginal bleeding. What are the features of this bleeding? This bleeding is going to be sudden in onset. Like patient will come and tell you that there was no any apparent cause, like there was no any history of trauma or anything else. She was just lying down, and suddenly when she got up, she found herself in a pool of blood. So the onset of placenta previa is sudden, and it is going to be painless and apparently causeless. No cause will be, apparently there will be no cause for that vaginal bleeding. It is going to be recurrent. Like there might be a history of warning hemorrhage. Warning hemorrhage can occur in first and second trimester, right? Warning hemorrhage is going to be slight bleeding without pain, and also it is going to stop within few minutes or within few hours, right? But if the separation increases in further trimester, if the separation of the placenta increases, then that might lead to recurrent hemorrhage, and which is going to be more in amount than in warning hemorrhage, which is going to be a slight bleeding. Alright, and that blood is going to be bright red in color because it is going to be a fresh bleeding, right? So these are your clinical features. Another thing, if you do the abdominal examination, you will find that the size of uterus is going to be proportionate to the period of gestation. There will be no change in the size of uterus. It will be proportionate, right? Uterus is going to be relaxed and soft, and FHS is going to be usually present unless and until there is a lot of separation or major degree of separation of the placenta from the uterine wall. FHS is going to be present because a slight separation is not going to hamper the gaseous exchange between the mother and fetus. So FHS is going to be usually present. And persistence of malpresentations or floating head. Floating head won't get engaged as we have seen in few cases, and malpresentations will be there because as the placenta is lying in the lower uterine segment, fetal head might not be able to come into the antero-posterior diameter, and that can lead to malpresentations in placenta previa. Alright. Another, the most important thing is that vaginal examination should not be done. It should never be done in placenta previa. So if a patient comes to you in third trimester or in later parts of second trimester and she says that she is having a PV bleeding, you should never do vaginal examination. You should send her for an urgent ultrasound. If there is no any prior ultrasound report present with her, you should send her for ultrasound, but should never do vaginal examination. So it is completely contraindicated in placenta previa. How are you going to do the localization of placenta? How are we going to understand the what is the location of placenta? We are going to do it by transvaginal sonography in third trimester. So you might get the doubt that PV examination is contraindicated, then how are we going to do transvaginal ultrasound? But in transvaginal ultrasound, we are going to put that probe just lightly into the vagina, right? We are not going to probe it over the cervix. So transvaginal ultrasound is safe and it should be done in third trimester. Now what is the reason for this third trimester? Why not in first and second trimester? Because it might happen that like if you're doing ultrasound at 18 weeks, you might find that it is a low-lying placenta. And in same case, if you do it at 32 weeks, you might find that placenta is normally placed. How does this happen? This is what we call as placental migration. Now here, placenta is not actually migrating from one place to another. But what happens due to the elongation of that isthmus or due to the formation of lower uterine segment, placenta automatically gets placed over the upper uterine wall. So that is why we have to do this localization of placenta in third trimester, because lower uterine segment gets formed in that trimester. So you are going to get the clear picture of location of placenta in third trimester. Alright. Now what could be the complications of placenta previa? First, let us understand the maternal complications. During pregnancy, she might go in shock. She might become hemodynamically unstable due to heavy bleeding. Malpresentations, as we have seen, it is commonly seen. Preterm labor might be induced or it might be spontaneous. Why induced? If there occurs an emergency, like mother is going into shock or the fetus is going into distress, then we need to terminate the pregnancy at that point, right? So preterm labor might be induced in that case. During labor, there might occur premature rupture of membrane, cord prolapse can occur, intrapartum hemorrhage, operative interference will be increased due to malpresentations, and due to grade 3 and grade 4 placenta previa. Postpartum hemorrhage can be present. Retained bits of placenta is also the complication of placenta previa. During puerperial period, sepsis, chances of sepsis might be increased due to anemia, due to blood loss, and due to increased operative interference. It can also lead to sepsis in puerperial period. Subinvolution and embolism can also be the complication of placenta previa. Now what could be the fetal complications? Low birth weight due to preterm labor. Baby might go in distress, asphyxia. Intrauterine death can occur. If there is complete separation of placenta, then intrauterine death can occur. Alright. So these are the complications of placenta previa. Moving on further, let us understand the management. So all antepartum hemorrhage patients are to be admitted in the hospital unless and until if she's like 32 to 34 weeks of gestation and there is no active bleeding, and if she is staying nearby the hospital, and if the patient is compliant, then you can send her home and tell that if even if slight bleeding occurs, you need to come to the hospital urgently, right? Otherwise all APH patients are to be admitted. So you're going to do the general and abdominal examination of that patient, and baseline investigation should be done like CBC, cross matching, blood grouping and all, because if she bleeds profusely you might need to do the blood transfusion. So everything should be ready in case the emergency arises. Resuscitation if she is going in shock. Localization of placenta should be done by ultrasound, by transvaginal ultrasound. Now another important thing is we need to decide whether we are going to do the conservative management or whether we are going to do an active interference. So for that, if the patient is symptomatic and if maternal and fetal status is stable, then we are going to go for conservative or expectant management. So what are the indications for that? First thing is that there should be no active bleeding present. Then the pregnancy should be less than 37 weeks because fetal lungs mature at 34 weeks of gestation. So if the pregnancy is less than 37 weeks of gestation, then obviously we can go for conservative management if other parameters are pointing towards it. So another thing is she should be hemodynamically stable. She should not be going in shock. Then the fetal heart rate should be reassuring. Fetus should not be going in distress, and steroid therapy should be given. So in all these cases, we can continue the pregnancy till 37 weeks under strict observation, and then after 37 weeks, we can terminate the pregnancy. Now, what are the other conditions where we need to do the active interference? So, if there is an active bleeding, if she is bleeding profusely, heavily, and if the bleeding is continuing in spite of any other treatment, then we should do the active intervention. Also, if the pregnancy is beyond 37 weeks, then the fetal lungs are already matured, she is already a term pregnancy, then there is no need to wait and wait for further spontaneous labor. You can terminate the pregnancy if she is having a pregnancy of more than 37 weeks. If she is hemodynamically unstable, if you feel that she is going in shock, then you should terminate the pregnancy. If the fetal heart rate is non-reassuring, if the fetus is going in distress, then also active intervention is needed. Okay, so how are you going to do the management in that case? First thing is hospitalization, resuscitation should be done, blood transfusion, then steroid therapy. If she is less than 34 weeks of gestation, then steroid therapy should be given for the lung maturation of fetus. Tocolysis if needed, and MgSO4 if the pregnancy is below 32 weeks of gestation, then for neuroprotection you should give MgSO4. Now, after that, ultrasound examination should be done, and based on ultrasound findings, how are we going to do the further management that is given? So the placental age, if it is greater than 2 to 3 centimeter away from the internal os, then we can give the trial of labor, right? Normal vaginal labor, we can give the trial by doing artificial rupture of membranes or by starting the oxytocin drip. But if there is no satisfactory progress even after that, then, and if the bleeding continues, then we are going to go for C-section. But if there is a satisfactory progress, then we can deliver the patient vaginally, right? And if the placental edge is within 2 centimeter, or if it is a low-lying placenta, then obviously you are going to go for C-section. And most of the women with low-lying placenta are delivered by cesarean section, right? And if it is a type 3 or type 4 placenta previa, then obviously you are going to go for C-section, right? So this is how you are going to deliver the patient of placenta previa. Alright, so this is all about placenta previa. Now let us take a few case studies. So this is your case 1. A 29-year-old G2P1 at 34 weeks presents with recurrent episodes of mild vaginal bleeding over the past 1 week. She has no abdominal pain. On examination, uterus is soft, non-tender, fetal head is high and not engaged, and FHS are normal. So what is the most likely underlying reason for the unengaged head? So it could be cephalopelvic disproportion. I'm sorry, this is your 38 weeks of gestation, okay? So it could be cephalopelvic disproportion, oligohydramnios, placenta occupying lower uterine segment, or fetal anomaly. So the most common cause here could be placenta occupying lower uterine segment, because there were recurrent episodes of mild vaginal bleeding, and without abdominal pain, uterus is soft and non-tender, FHS are also normal. So the most common cause could be placenta previa, or the placenta occupying the lower uterine segment. Okay. Another case, a 30-year-old G2P1 at 38 weeks presents with active vaginal bleeding. USG shows placenta covering internal os, type 4 placenta previa. What is the best management in this case? Expectant management? No, not at all. You need some active intervention. She is having active vaginal bleeding and it is a type 4 placenta previa. Induction of labor? Also no. Emergency C-section, as it is a type 4 placenta previa and she is having active vaginal bleeding. You are going to do emergency C-section. Alright. Now, another thing. A 26-year-old at 32 weeks presents with bleeding per vaginum. Vitals are stable. FHS reassuring. Bleeding stops after admission. So what is the next best step? Immediate C-section? Is it needed right now? She is 32 weeks of gestation. Fetal lungs are not yet matured. Emergency C-section should not be done. Bleeding per vaginum, vitals are stable, FHS are reassuring, and bleeding stops after admission. So right now there is no active bleeding. She is below 37 weeks of gestation. Fetal heart rate is reassuring, vitals are stable, she is not going in shock. So all are pointing towards the expectant management or the conservative management. So option B, expectant management with steroids, is the correct answer. Okay. Alright, so thank you so much everyone. In next session we are going to learn about abruptio placenta. Okay. Thank you.